In terms of current treatment options, there are two FDA-approved therapies. Both work to slow disease progression. Neither of them are a cure. In addition to these therapies, there are other management strategies, including supportive care and other non-pharmacologic measures for patients with IPF. Some of these patients will have their course complicated by the development of acute exacerbations, but therapy for this is mostly unproven, and the course, once patients develop a true acute exacerbation, the course tends to be pretty dismal with a very poor prognosis once this sets in. Lung transplantation is available for select patients who have advanced IPF, provided they are young enough and don't have limiting comorbidities that might preclude their lung transplant candidacy. In terms of supportive care, supplemental oxygen is something to consider in those patients who have significant and sustained desaturation, be it with exercise or nocturnal desaturation. Pulmonary rehab is something that all patients with IPF can and will benefit from as the disease progresses and as they become more impaired in terms of their shortness of breath. Pulmonary rehab includes education, aerobic conditioning, strength and flexibility training, education, nutritional counseling, psychosocial support. These are all very important components of a comprehensive pulmonary rehab program. As patients head towards the late stages of their disease, mechanical ventilation is really futile care, in my opinion, unless the patient is being considered as a potential lung transplant candidate. And if patients, or ideally before patients get to this point, palliative care services and hospice should be brought in for discussion and a transition of these patients to more of a comfort care type of situation. The governing bodies, including the American Thoracic Society, European Respiratory Society, at various time points have come out with guidelines in terms of therapies to use and therapies not to use in patients with IPF. Unfortunately, mostly it's therapies not to use, including anticoagulation, unless the patient warrants anticoagulation for another reason. This is based on the ACE study of warfarin that showed that this was actually harmful, increased hospitalization, increased mortality in patients with IPF. Imatinib has also been studied in IPF. There was no benefit to this. All three ERAs, endothelin receptor antagonists, have been studied in IPF without any benefit, including ambrisentan, bosentan, and macitentan. Then a message that still needs to get out more is the role or lack of a role for immunosuppressive therapy in the form of prednisolone and azathioprine. Prednisone and azathioprine were recommended as recently as about, 13, 14 years ago. Sorry, let me do my math again. More like 2 decades ago, we were recommending azathioprine and prednisone, and it's since been shown through the Panther study that not only does prednisone and azathioprine not work, but they're actually harmful. They're actually harmful to patients with IPF, with increased hospitalization and mortality from these two agents. These were studied together with N-acetylcysteine. N-acetylcysteine by itself neither helps nor hurts patients with IPF. So not something that's recommended, but at least it's not harmful.